Healing Minds, Changing Attitudes is underwritten by the Arkansas Mental Health Research and Training Institute.
Hello and welcome to Healing Minds, Changing Attitudes. I'm your host, Pamela Smith. Approximately 3 in 100 people will experience an episode of psychosis during their lifetime. That's according to the National Alliance on Mental Illness. We're going to take a look at First Episode Psychosis, also referred to as FEP, and discuss what it is and the type of care and treatment mental health professionals are providing right here in Arkansas. Joining me for this very important discussion are Dr. Roland Irwin, a clinical psychologist and the clinical director at Mid-South Health Systems, Dr. Lisa Evans, clinical director at Little Rock Community Mental Health Center and assistant professor at the University of Arkansas for Medical Sciences, Department of Psychiatry. Tony Sisson, a licensed professional counselor and adult services division director at Community Counseling Services Incorporated. Also Dr. Justin Powell, a psychiatrist at Little Rock Community Mental Health Center. Thank you all very much for joining us for this very important, I would like to say, continuation of a discussion that we actually began in the fall about FEP, as it's referred to commonly, or First Episode Psychosis. Dr. Irwin, if you don't mind, remind our viewers about the definition of psychosis, exactly what that is.
Okay. Psychosis it's a general term that refers to a collection of symptoms that can occur in a number of different disorders, mental disorders. But it generally refers to when a person is having a break in what we call their contact with reality. Mm-hmm. So they get to a point where they can't distinguish between what's real and what's not real. For example, they might believe that they're hearing voices when those voices really aren't being said by anyone. Or they might have beliefs that aren't true. We call that delusions. For example, they might have the belief that someone is able to hear their thoughts. And those are just some examples of what could occur to someone who's having psychosis.
Well, when we hear about first episode, talk about the distinction. Why is that term commonly or being commonly used now? You want to take a stab at that?
Well, first episode psychosis refers to those first symptoms, that first time that particularly someone between the ages of 15 and 24 may be experiencing their first symptoms, delusions, hallucinations, withdrawals. It really is one of the most crucial times in someone's treatment history, because studies show that when someone experiences their first psychotic break, that if they get treatment quickly, then the prognosis is much better.
Mm-hmm. So are we seeing this happening at a younger age? Are we able to diagnose it at a younger age? What's the distinction between first episode and somebody who might be diagnosed a little bit later?
I would say that primarily a triggering event might be, for example, life transition, life stressors. Maybe they're leaving high school, they're graduating, they're getting a job, they're getting married. Anything that's a major life stressor could trigger a first psychotic break, mm-hmm. or trigger the first symptoms. So recognizing those symptoms very soon and very quickly would help them progress and do much better in treatment. And
sure.
You might be able to explain it better than me, Lisa.
And what really the distinction is to make sure that we're catching it very early. Sometimes the symptoms are more subtle early on, so trying to educate the community about how to identify that quickly and reduce the disability that might be caused by the illness. So not catching it early could lead to more severe disability, longer disability. So trying to catch it in that first episode and really get people back to work, back to school, and back to life.
Back to as much of a sense of normalcy
Absolutely.
as they possibly can have. Well, we were talking earlier about the diagnosis, and I can't remember which one of you, it actually might have been you, Dr. Powell, that talked about the age where you might actually begin to identify someone as having a first episode.
So
or
some
the
of
age range.
The age range, like you said, early adolescence. So kind of around, a lot of times it's around 18 to 22, kind of that range. That's probably kind of the highest density of when we see the first episode occurring. And so like some of the warning signs or some of the early symptoms, like we talked about briefly, was kind of social withdrawal. You mentioned like decline in their role functions, like they're in the middle of college and all of a sudden their performance declines and nobody really knows why. Those are the kind of things that like family could help identify. Like there's something different. They're not doing as well as they used to do before. They're withdrawn.
They might be.
I'm sorry, go ahead.
Or they might be displaying what we call suspiciousness of others. Kind of guarded, behaving as if they feel that others might be watching them.
So kind of paranoid.
Kind of paranoid, yeah. They might be a little more irritable than usual. And when you get them to try to explain why they're feeling that way, their explanation doesn't really fit with what you would think ought to be going on with them at the time.
Well, what I'm hearing from you, though, sounds like it could mimic a lot of other challenges that someone who's been diagnosed with mental illness may face. So how do you know what the distinction is?
I'd say it's really important to get in and see a clinician. I think it's important to get help, but if you have a family member that supports them and recognizes that they're having these types of behaviors or exhibiting these types of behaviors, and it's not primarily just a teenage or a young adult phase they're going through with withdrawing, particularly if it's unusual, like Dr. Irwin mentioned, that we get them in to see a professional and get them assessed quickly. I think that's probably the key.
Well, speaking of getting them in to see professionals, I know in our last program in the fall we talked about the work that's being done in Arkansas. How are we doing now since the fall? Dr. Irwin?
Well, since I guess we began in earnest across all of the mental health centers in Arkansas, an effort to begin to identify individuals experiencing first episode psychosis. So that started in October of 2015. And now all the mental health centers are keeping track of how many clients that we have that are identified with this. We have taken a number of our staff in each of our centers through several different training opportunities that have been very good. And Dr. Evans can talk about what some of those training opportunities were if you want to.
Yeah, so some of the trainings that we've been able to provide for our staff, one really great training was a 2-day training on family psychoeducation. And it's a manualized treatment that is delivered to the person with psychosis and also their identified family member or their support system. And it gives very specific ways of engaging the family and the client and bringing them into the clinic and being able to provide information, education about psychosis, how to manage it within the family system, how to keep somebody who often doesn't want to engage with clinicians and providers as engaged as possible, keeping family members involved so that we are able to help them when they do go off their medicine or potentially relapse. So we've been through that training. A lot of our staff have been through that training, as well as other individual type interventions like cognitive behavioral therapy is also another intervention that can be used for psychosis. Individual resiliency training is another one that we're trying to bring to our staff to provide interventions at the individual level.
So it sounds like you've really tried to do a concentrated outreach effort.
Yeah, we were trying to get our staff trained and educated about how to provide services to this population that's a little bit difficult to treat, a little bit difficult to engage, but also to educate the community to help us quickly identify people and bring them to trained clinicians so that we can figure out what's going on and what the best next step is.
Okay, hold that thought, because I want somebody to explain why this population may be difficult to treat. Dr. Powell?
So it's an illness that probably, unless you have a first-hand experience with, a lot of people don't know near as much about schizophrenia as they do about depression or anxiety, just because those are more prevalent. They're more likely to have seen that portrayed in media, even things like that. So it's more rare, but it's a pretty serious illness. As far as the reason they're hard to engage in treatment, not only do they might not have much experience with even what the illness is, it's hard for them to wrap their minds around that they have this illness. That's kind of a hard illness to understand. Even after they have their first symptoms that may even land them into, their family may basically get them into the hospital for treatment. Once they get on some medication that really treats a lot of the like hallucinations or the paranoia, suspiciousness, if they have medicine that treats those symptoms and they go away, they may just think that the illness is basically cured and that they don't need to continue the medicine after the symptoms are gone. But I mean, we just know from decades of research that it's extremely important that with a diagnosis of schizophrenia that they continue medications basically indefinitely, because the more like psychotic episodes we can prevent, the healthier that is for the brain. When the brain is in a psychotic episode, the first psychotic episode or even the subsequent ones, that's the longer time they spend in that episode, the harder it is for the brain to recover. So kind of if we can prevent as much of those psychotic symptoms as we can preserve a higher level of functioning.
So in addition to taking the medication, well actually I really wanted to ask you a question related to not taking the medication, and you're saying people are feeling that they're better so they don't need it anymore. Is there a chance that you ever have to decrease the medication, or is that something that a patient would have to have available throughout their life?
So certainly the dose of medications would change over time. The choice in specific medications may change over time. A medicine that they respond to at the very beginning, they may not respond to as well later down the road. So there are changes in treatment definitely that take place over time. Sometimes a change in medication is warranted because the side effects for one person are just not really tolerable. So there's a lot of individualizing treatment for the patient, for the specific symptoms and kind of the side effect profile of different medications.
Well, I'm sorry, go ahead.
Sometimes it depends on, or it is determined by what the diagnosis turns out to be. So we're talking about first episode psychosis, which could be schizophrenia, which is what Dr. Powell's talking about, or it could be less often we see people come in with essentially the same collection of symptoms, the voices and the delusions, and they've been on a lot of drugs, and certain kinds of drugs can cause those symptoms. So sometimes we'll see a client who comes in and we get them on medication for a while, get them off the drugs, and then eventually they stop taking the medications, and it turns out that all of their symptoms were caused by their drug use. That would be less often, but that's a possible outcome
That's
too.
a consideration. Well, we talk about denial. Let's talk about the stigma, because there is still such a strong stigma associated with people seeking help for mental illness. We're ever going to be able to get over that hump?
Absolutely. I'm a believer in that. And I do think we have to take it one day at a time. I see challenges in this every day, both in our community and the clients that come to see us. They also have bias about mental illness. And even sometimes in clinicians, we have to sometimes retrain people to educate them about schizophrenia and psychosis and the ability to recover or return to a normal life, that there is hope there. So I think the thing that we need to do is to educate the community and families and clients about treatments that work and how to get them, how to advocate for them in our communities with our legislature. So those are some of the things that we hope to be able to do over the course of the next few years, is bring these treatments that work here to Arkansas and really make a difference.
How key is having family support, and then beyond just having immediate family support, having a support system for the families who are the supporters?
Family support is crucial. I mean, we were talking just before we came on the air about how with our experiences, our clients who have good family support are just so much more successful. When you think about it, just to one day have to face the reality that you have a chronic medical condition if it's schizophrenia, that it's going to have to be treated for the rest of your life. That's hard to accept. And they need a lot of support, and if they have family who can help them to accept that, and we'll be with you, we're going to help you through this, it just makes all the difference in the world. And you know, families, when you have a child who is suddenly experiencing the kind of symptoms we're talking about, and they have to be taken off to a psychiatric hospital, that's a crisis for that family. And that is extremely frightening. And families need a lot of support and a lot of help with that. And that's what that psychoeducation is about, teaching them that this is a serious illness, but it can be treated. And the success rate for treatment is very good if we can keep them on the medicine.
And like Dr. Powell said, a lot of people don't have an experience, a first-hand experience with somebody with schizophrenia or with psychosis. And so it's so meaningful to have a family member be able to talk to people who have known somebody with schizophrenia, have seen people recover, and really know kind of what it feels like to have that suspicion aimed at you. It's very scary for family members, and so it's nice for them to have somebody who really understands what that's like.
So once we educate the family, they have a better understanding, and they're more likely to follow through.
Right.
So not only educating the family, but educating the patient or the client that comes in to see us, because like we mentioned before, they really don't know what's going on. And in many cases, they'd much rather admit that they had a drug or substance abuse problem than to admit that they had a mental health or mental disorder. And so the education, as you mentioned, Lisa, is extremely important. And you know, people, that's one of the first things we do when someone comes in the door, is we try to educate them on their illness. Develop that rapport, develop trust and relationship with them, and make sure that we provide them educational material that explain what's going on with their child or loved one.
Well, say we have a family member watching who says, well, my loved one has experienced this, but I can't get them to get help. What should that person do?
I'd say don't stop. Keep trying. Call the office, try to get them to make an appointment, bring them to our walk-in clinics. And most all of us have a walk-in clinic where you can just walk in.
The local mental health centers can really educate family about kind of what to do in the moment. We have a lot of knowledge about how to use the mental health system, how to access the mental health system, how to access, if necessary, a court order to maybe perhaps court order a person into treatment for a brief period of time so that we can ensure to get them engaged, get them on some medicine that's really critical. And then, of course, eventually they would engage in treatment on their own. And so we can usually help a family member to really understand what their options are for getting a family member engaged.
Navigating the resources.
Yeah.
Explain.
Right.
Yeah, I can imagine that probably would be a daunting challenge for families who've never experienced it or don't know exactly where to go for resources to even navigate the system. So their first step is to contact a mental health service provider. Is that what you recommend?
I would say that would be the first step.
A local community mental health center in their area who would really know all of the resources locally and be able to advise them on the best, most respectful way to intervene with their family member.
So what about therapies? Are there any new therapies that are on the horizon that you guys see really making a difference on behalf of patients? I see you nodding emphatically, so go right ahead.
I know a lot of great things that so the things that we're working with First Episode Psychosis, some of the things I've mentioned, family psychoeducation, we know has been effective in helping people get back on their feet and get into their lives. I mentioned illness, individual resiliency training, which again is an individualized treatment that helps tackle the specific things that are going on with that person, whether it's substance abuse or trying to get back to work or paranoia. Supported employment is also an intervention that has been well researched and that we know is effective in getting back a lot of people into work or education who want to. It's a very intensive intervention and requires highly trained staff who know how to do vocational interventions and supported employment. I think there are a lot of really well-researched interventions for people with psychosis and schizophrenia, in particular early episode psychosis, that are working.
And another thing that we don't have much of here in Arkansas, we don't have a good way to fund it, is peer supports.
Yeah.
And that's where you have someone who is in the midst of or in the process of recovering from psychosis, has learned how to deal with it, and then that person can even become an employee of a mental health center. And you know, hearing the message of we can help you through this from someone who is experiencing it,
Right.
it just sounds different than a psychologist saying that to someone in the middle of a first episode of
I've
psychosis.
been where you are.
Exactly. And so, you know, we would love to have the opportunity to do more of that in Arkansas, and I think that's maybe on the horizon.
The other thing we know that works is medications.
Yes.
And we've known that works for a long time, but there's new medications that come along fairly often, including medications that are injectable, so that somebody doesn't have to remember to take a pill every day.
That can help. An injectable medication can help a whole lot at the beginning when they're not really sure if they have this chronic illness, and then kind of following that is they're not really sure if they have to take the medicine every single day. They may think they only need to take the medicine on the days they kind of feel a little bit worse. But a long-acting injectable, the advantage of that is there's at least no kind of secretly not taking the medications. If they're scheduled to get an injection once a month and we know the medicine is in their body and their brain for the whole month, they miss that, then we kind of know this person's basically getting behind and we need to spend more time and resources reaching out to this person because they missed. So it can cut down on just lack of adhering to the treatment plan, to kind of everybody being on the same page.
Is that a very expensive therapy, though?
Some are pretty expensive. Some are pretty expensive. Overall, there's generally all of the health plans cover at some options for that, though.
Oh, that's good to hear.
Yeah, we can basically always get somebody on a long-acting injectable, one that's covered by their plan.
Well, that's exciting to hear that there are those new kind of therapies that have a longer lasting effect, and therefore hopefully lessen the likelihood of someone not taking the medication that definitely needs it. Let's talk very quickly, because unfortunately we're almost out of time. This always happens when we really get down into the meat of our discussion. But talk very quickly, if you don't mind, about funding. How are we doing in Arkansas? Are we needing to do better?
I think we could always do better. I mean, there's probably never enough money to treat the illnesses that really need to be treated. It's still, unfortunately, like mental health or behavioral health is still one of those areas that's underfunded. I'm not certain why that is. I think it's something that we don't take as serious as we need to. I say as a society, I think we're getting better. But I think we can do a lot better, especially with the wraparound services that we provide. We probably do a really good job at providing professional services, but when it comes to case management or those supportive services that we can help people get a job, get vocational training, supportive employment, supportive living, activities of daily living type skills, those are the things we really struggle to fund.
Now, when you say supportive employment, are you referring to actual employers being understanding and supportive of the process, or am I misunderstanding?
Actual intervention that is gets people real live jobs in the community, just like you and I would get, and provides a specialist who knows how to go to that job and help that person keep that job. When they're having trouble on the job, they would intervene while on the job. They would get to know the employer and help the employer understand mental illness, talk about breaking down barriers and stigma. That's what's happening. So when you have a really strong supported employment program where you have staff going out and doing that kind of thing, that really helps that person keep that job and also educates the community.
Are we seeing progress in that area?
Not yet.
Okay, it's got to work on that.
It's not yet. Yeah, not yet. Consensus.
Still more work to do.
Yes, there's some work
All right.
there.
Well, very quickly, if you don't mind, Dr. Irwin, because we always like to leave people with a sense of hope, because that's what this conversation is about. It talks about the challenges, but we know there's hope. So very quickly, express what families need to know.
Well, I guess I'll just tell you what gave me a lot of hope when last year, a year and a half ago, when we all started learning more about this, and is that if we identify somebody early on who's having these symptoms and we can get them in and if we can get them on medication, their response to that medication is, well, matter of fact, they tell us now, SAMHSA, the researchers tell us, the goal should not be just to decrease the symptoms. The goal should be complete recovery from those symptoms. And medications are extremely effective. And the trick is identifying, getting them in for treatment, and then keeping them on the medicine through a lot of support. And so there's, even though this is a very kind of frightening kind of diagnosis, the hope should be there, and because treatments are very effective.
Well, thank you very much. Thank you all for sharing your insights on this very important and timely topic. And we thank you for watching. We hope you've gleaned some useful information that will help you lead healthier lives. Good night.
Healing Minds, Changing Attitudes is underwritten by the Arkansas Mental Health Research and Training Institute.